Dear students, I am full professor Dušica Marić. Welcome to the first lecture, Anatomy of the Upper Limb. Now we shall start with the bones. The upper limb is divided into the shoulder region, the arm, the forearm, and the hand. The bones of the shoulder region are the clavicle or collarbone and the scapula or shoulder blade. They articulate with each other and form the shoulder girdle. The arm is the part of the upper limb between the shoulder and elbow or cubitus. The bone of the arm is humerus, which articulate with the scapula at the shoulder joint and upper ends of the radius and ulna at the elbow joint. The forearm is the part of the upper limb between the elbow and the wrist. The bone of the forearm are radius and ulna. These bones articulate with humerus at the elbow joint and with each other, forming radio-ulnar joints. The hand or manus consists of wrist or carpus, hand proper or metacarpus, and digits, thumb and fingers. The shoulder region is the area of the upper limb attachment to the trunk, and the pectoral girdle is the part of the chest. Maybe you think now, why we learn clavicle and scapula together with the bones of the upper limb? Because the humerus articulates with the scapula articulates with the clavicle, and when the shoulder joint is moved, both the scapula and the clavicle are moved together. Therefore, they represent one functional unit. When you learn bones of the upper limb, you will recognize the position of the sternum, clavicle, scapula, coracoid process and acromion process of scapula, and position of proximal part of humerus. The clavicle or collarbone, in Latin clavicula, is located horizontally on the anterior aspect of the body at the junction of root of the neck and trunk. It articulates medially with the sternum and first rib cartilage and laterally with the acromion process of the scapula. It is subcutaneous and hence it can be palpated through its entire extent. It is the only bony attachment between the trunk and upper limb. The clavicle consists of three parts, two ends, medial and lateral, and the shaft. The shaft lies between the lateral and medial ends. The medial or sternal end articulate with sternum. The lateral or acromial end articulate with the acromion of scapula. The clavicle is the long bone with a slight S-shaped curve. Medial 2/3 of the shaft is round and its lateral 1/3 is flattened. On the shaft we can describe superior and inferior surfaces. The superior surface is subcutaneous and smooth and palpable along the skin. The inferior surface of the shaft possesses a small groove in its middle third. The superior surface of the shaft is subcutaneous between the attachments of deltoid and trapezius muscles. The anterior border is concave forwards and gives origin to deltoid muscle. The posterior border is convex backwards and provides insertion to the trapezius muscle. On inferior surface, subclavius muscle is inserted into the subclavian groove. The subclavian groove is an oval impression. The lateral or acromial end is flattened above downwards. An oval facet on this end articulates with a facet on the medial margin of the acromion to form acromioclavicular joint. It presents a conoid tubercle and trapezoid ridge, which provide attachments to conoid and trapezior parts of coracoclavicular ligament. The conoid tubercle is located on the inferior surface near the posterior border at the junction of the lateral 1/4 and medial 3/4 of the clavicle. The trapezial ridge extends laterally from conoid tubercle. The enlarged medial or sternal end has a saddle-shaped articular surface which articulates with the clavicular notch of manubrium sterni to form sternoclavicular joint. It provides attachment to fibrous capsule, articular disc, and costoclavicular ligament. On the inferior surface of the sternal end, the costoclavicular ligaments is attached to an oval impression. In this picture you can see rough impression for costoclavicular ligament. The side of clavicle can be determined by holding the bone horizontally in such a way that its flattened end is on the lateral side and its enlarged quadrilateral end is on the medial side. The convexity of its medial 2/3 and concavity of its lateral 1/3 face forwards with longitudinal groove in the middle third of shaft facing inferiorly. The clavicle is the most commonly fractured bone in the body. It commonly fractures at the junction of its lateral 1/3 and medial 2/3. When fracture happens, the lateral fragment is displaced downward by the weight of the upper limb because trapezius alone is unable to support the weight of the upper limb. The medial fragment is slightly elevated by the sternocleidomastoid muscles. When we think about broken collarbone, we have to think about subclavian vein, subclavian artery, and nerves, parts of the brachial plexus, because they descend from the neck to the chest and upper limb and lies behind the collarbone or clavicle. And parts of the fragments of clavicle is like a knife, and that knife can cut the artery, veins, and nerves. The scapula, shoulder blade, is a large flattened and triangular bone located on the upper part of the posterolateral aspect of the thorax against 2nd to 7th or 8th ribs. It is a typical flat bone. The scapula is highly mobile and consists of 4 parts, a shaft and 3 processes: spinos, acromion, and coracoid. The ventral surface of the scapula have connection with the ribs, and that is the reason why we call that surface costal surface. On the costal surface we have a depression, subscapular fossa. It is concave and directed medially and forwards. It presents 3 longitudinal ridges which provides attachment to the intramuscular tendons of subscapular muscle. The dorsal surface is convex and presents a shelf-like projection called spinous process. The spinous process divides the dorsal surface into supraspinous and infraspinous fossa. The upper supraspinous fossa is smaller, 1/3, and lower infraspinous fossa is larger, 2/3. The shaft of scapula consists of 3 borders and 3 angles. The red line represents position of superior border, the green line medial border, and the blue line represents position of lateral border. The number 1 represents position of superior angle, number 2 or inferior angle, and number 3 position of lateral angle. The superior border is the shortest border and extends between superior and lateral angles. The suprascapular notch is present on this border near to the roof of coracoid process. The medial border extends from superior to the inferior angle. The lateral border is the thickest border and extends from inferior angle to the glenoid cavity. The superior angle lies between the superior and medial border. The inferior angle lies between the medial and lateral border, and the lateral angle lies upper from the upper parts of lateral border. On the upper end of the lateral border we have one elevation. It's called the infraglenoid tubercle. The long head of the triceps brachii arises from the infraglenoid tubercle. On the lateral angle, or the other name is the head of the scapula, we have a large comma-shaped depression. It's called the glenoid cavity. The glenoid cavity articulates with the head of the humerus to form glenohumeral or shoulder joint. Superior from the glenoid cavity, we have another elevation. It's called the supraglenoid tubercle. The long head of the biceps brachii arises from the supraglenoid tubercle. This origin is intracapsular. The Spinous process is a shelf-like bony projection on the dorsal aspect of the shaft. The acromion process projects forwards. The coracoid process is like a bird's beak or hook. It arises from the upper border of the head and bends sharply to project supero-anteriorly. The site of the scapula can be determined by holding the scapula in such a way that the glenoid cavity faces laterally forwards and slightly upwards. The coracoid process is directed forwards. The Spinous process is directed posteriorly. The scapula located in a protected place, so it rarely breaks. When it does, it is an indication that the individual was subjected to a considerable amount of force and that severe chest trauma may be present. If we have a fracture of scapula, we have to think about suprascapular artery, nerve, long head of triceps, or circumflex scapular artery and axillary nerve, because broken parts of bones can injure these arteries and nerves. The humerus is the bone of arm. It is the longest and strongest bone of the upper limb. The humerus is a long bone and consists of three parts: upper end, shaft, and lower end. The shaft is a long part of bone extending between its upper and lower ends. It is cylindrical in the upper half and flattened antero-posteriorly in the lower half. We can describe three surfaces and three borders. We have anterolateral surface, anteromedial surface, and posterior surface, and anterior, medial, and lateral borders. The anterolateral surface lies between the anterior and lateral borders, a little above the middle. This surface presents a characteristic V-shaped tuberosity, the deltoid tuberosity, which provides insertion to the deltoid muscle. The anteromedial surface lies between the anterior and medial borders. The upper part of this surface forms the floor of the intertubercular groove. The posterior surface lies between the medial and lateral borders. In the upper one-third of this surface, there is an oblique ridge directed downwards and laterally. This ridge provides origin to the lateral head of the triceps brachii. Below and medial to the ridge is the radial groove, which lodges radial nerve at profunda brachii vessels. The upper end of humerus presents the following 5 features: head, neck, greater and lesser tubercle, and intertubercular groove. The head is smooth and rounded and forms less than a half of a sphere. It is directed medially backwards and upwards. It articulates with the glenoid cavity of scapula to form the glenohumeral or shoulder joint. Anatomical neck separates head from greater and lesser tubercle. The greater and lesser tubercle representing two elevations, large and small elevation, for the muscle attachment. The surgical neck separates upper end of humerus from shaft. Intertubercular groove is one depression for the long head of biceps brachii. Near the lower end of the humerus, the black arrows show you position of two elevations for the muscle attachment, that is the lateral and medial supracondylar ridge. The inferior third of the medial border of the humerus is raised into a slide ridge, the medial supracondylar ridge, which becomes very prominent below. The lateral supracondylar ridge is a prominent rough margin on the lower part of the lateral border of the humerus. Lower end of the humerus articulate with the upper parts of the radius and ulna in elbow joint. That is the reason why we have only one articular part, condyle, and orange color represent position of condyle, and two non-articular parts, lateral and medial epicondyle, and blue color represent position of epicondyles. The lower end presents the following 7 features. Capitulum is a lateral round and convex projection which articulates with the head of the radius. The trochlea is a medial pulley-shaped structure which articulates with the trochlear notch of ulna. The radial fossa is a small fossa above the capitulum. The coronoid fossa is a small fossa above the trochlea. Medial epicondyle is a prominent projection on the medial side. Lateral epicondyle is a prominent projection on the lateral side, but less than the medial epicondyle. Olecranon fossa is a large, deep hollow on the posterior aspect above the trochlea. On the posterior surface of medial epicondyle, we have ulnar groove for the ulnar nerve. The side of humerus can be determined by holding it vertically in such a way that the rounded head at the upper and faces medially backwards and upwards, the lesser, greater tubercle and intertubercular groove at the upper and faces anteriorly, the olecranon fossa on the lower flattened end faces posteriorly. In the top right corner, you can see the most common fractures of the humerus. Fractures of the humerus are classified in A. Proximal humerus fracture, B. Humerus shaft fracture, and C. Supracondylar fracture. Proximal humerus fractures commonly occur in the elderly, while distal supracondylar fractures are the most common type of fracture in the pediatric population. If we have broken parts of humerus, we have to think about axillary nerve around the surgical neck of humerus, radial nerve in radial groove, and ulnar nerve behind the medial epicondyle. Dear colleagues, for upper limb learning, I recommend you Gray's Anatomy for Students. If you have any questions and suggestions, you can send me email.